Hey, and did you know I'm currently accepting new patients in New York, offering both in person and telehealth visits? And I also provide telehealth for patients in Michigan, with North Carolina coming soon. And I also offer coaching, both intimacy coaching and menopause coaching, nationally and internationally. So look us up on www.femvhealth.com. I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about updates in menopausal hormonal therapy. This is not any type of medical advice. So if you're having any hot flashes, night sweats, mood swings, you can come to my office. I have an office in New York and I do telemedicine for Michigan and soon North Carolina as well. Or you can go to the menopaussociety.org if you are not in any of those states and get the help that you need. And remember, this is not any type of religious advice. So if you have any questions about your religion, make sure you go speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So let's get a little bit into, let's talk a little bit about pharmacology. Okay, so we're going to talk about a little bit about formulation and route selection and what's going on there. So oral estrogen. So we have oral estrogen products like estrase and Premin. It's in the most extensively studied route and the one that is represented in the original WHI study, right? So that was the athenyl, the conjugated equine estrogen, right? That was the WHI study one. It's effective for vasomotor symptoms and it has decades of safety, right? However, the oral estrogen does undergo the first pass effect in the, right? So anything taken through the mouth that has to go into the, through your GI system. And because it undergoes the first pass hepatic effect metabolism, it means that sex hormone binding globulin elevates clotting factor production and raises triglycerides and can cause a higher VTE and stroke risk compared to transdermal. So anytime we give out hormones, it's usually, we don't really give out oral estrogen, although it is helpful for some women because listen, not everyone absorbs, and so I have women that are on transdermal that are not absorbing well. And, they may have to go on oral. Okay, so transdermal estrogen are patches, gel sprays, and they do not go through the first pass effect, right? They're not going through the liver. They're not being metabolized by the liver. And so the serum levels tend to be more stable. The VT risk is not increased. This is supported by multiple observational studies, okay? Vaginal estrogen. All right, so this is also one. It's important to know that it comes as a cream, a tablet, a ring, has minimal to near negligible systemic absorption at standard doses. This is important because it means that a lot more women can take vaginal estrogen, right? That can't. So women can also, right, if they cannot get the vaginal estrogen, then vaginal DHEA is also really good. Vaginal estrogen is FDA approved for GSM and at local doses. It's not systemically absorbed. So, of course, we don't need the progestin, right, with this. Okay, so the progesterone selection. So this is really why it's important, is that every woman with an intact uterus who receives systemic estrogen needs a progestogen to prevent estrogen-driven endometrial hyperplasia and carcinoma. But this is important because we have to know what type of progestin that we are prescribing. Let's talk about the progestogen, okay? So micronized progesterone is a body-identical progesterone. It has the most favorable safety profile of any available progestogen. Okay, so observational data particularly. So there was this large French study that was done as a prospective cohort study. It's called the French E3N study, and it was published in Breast Cancer Research in 2008. Okay, so the French E3N was a study that was initiated in 1990 and enrolled about 100,000 women aged between the ages of 40 to 65. This study was the first to show that breast cancer risk varies by the progestogen used in combined hormone therapy. So it showed that if you use transdermal estradiol, right, so that's a body identical estrogen combined with the micronized progesterone, which is the body identical progesterone, that was not associated with an increased breast cancer risk over 8 years. This is in contrast to the conjugated equine estrogen plus medroxyprogesterone acetate, which, remember, it showed that there was a slight increase, but it wasn't statistically significant. And so the micronized progesterone also has a sedating effect, right? So it can cause you to become very drowsy. And so we tell women to take it at night. And that's really important. Okay. So synthetic progestin. So we use those. We do. And we don't use them as often. We try to use the micronized progesterone because we know it has the most amount of safety data. But if you need the synthetic progesterone, which are definitely much stronger, that, that is it. If you use that one, those are more strong to help, especially for those individuals that, let's say, have some bleeding. But for the most part, we'll use that micronized progesterone. Okay. So in the WHI study, the conjugated equine estrogen alone significantly reduced breast cancer risk and breast cancer mortality. And that was really important. The medroxyprogesterone acetate was the progestin used in the WHI arm, and it was associated with an increased breast cancer risk reported in that study. But remember, we know that it was, there were not statistically significant, right? Initial unadjusted statistics from the WHI reported that women that began hormones, menopausal hormonal therapy, had a higher rate of developing coronary heart disease, stroke, and breast cancer relative to the placebo. After statistical adjustments, we saw that there was no statistical significance. Okay, so even though this medroxyprogesterone acetate has gotten a bad name because of the WHI study, we know that those results were not statistically significant. Okay, the most important results of 20-year median follow-up of menopausal hormonal therapy does not show, right, an increase in breast cancer mortality, and there was no statistical significant effect of combined menopausal hormonal therapy with breast cancer mortality. But there was actually a reduction in breast cancer mortality with estrogen alone. Okay, so that's really important to know. So a lot of the fear with hormones is it going to increase my risk of breast cancer? And so what the studies are saying is that no, it's not going to increase your risk of breast cancer, especially if you use those body identical hormones, which are probably the safest. Okay. This is going back to another thing is that the IUD, so the Mirena IUD, provides local endometrial protection, can be used alongside of systemic estrogen, which I have a lot of people on, for up to 5 years in perimenopausal and postmenopausal women. An important caveat is that IUD, if the IUD is malpositioned, you're going to have some bleeding. If it is more than 2 centimeters from the fundus or partially coming out of the cervical canal, then we have to assume that it's not placed properly, right? So you want to check the positioning via ultrasound. Okay, so the relationship between progestin only contraceptive and breast cancer risk is inconsistent. Okay, so that's something that we have to realize. Okay, so there is also progestogen-free option, which is the basidoxifene plus conjugated equine estrogen. It comes in a brand name called Duvi, and it's FDA approved for selective estrogen receptor modulator instead of progesterone, and it protects the endometrium. So if you are trying to find a hormone that would be protective against, prevent buildup of the lining of the uterus and also protective for the breast, you want to use Duvi because it is a combination that uses a selective estrogen receptor modulator instead of progestogen to protect the endometrium. And it's also indicated for vasomotor symptoms and for osteoporosis. So the reason why basidoxifene is important is that, let's say somebody has an increased risk of breast cancer, right? So you want to offer them hormones, but you want to give them something that won't potentially increase, right? We know that it was not statistically significant, but potentially increase the risk of breast cancer. Okay, so let's talk a little bit about testosterone. So testosterone is probably one of the most neglected hormones. Okay, I want to just spend a few minutes on testosterone because it is important. Testosterone levels in women decline gradually with age and drop sharply by approximately 50% with a bilateral oophorectomy. So if somebody's had their ovaries removed, testosterone declines by 50%. Okay, so the indication that we have currently for testosterone, okay, what is it? So can women have testosterone? Yes, they can. The indication put forth by the ISHWISH and by the 2019 Global Consensus Statement on the use of testosterone for women was that it is for hypoactive sexual desire disorder, which affects about 30% of postmenopausal women, and only about 10% of those are being treated. There's of course no FDA approved testosterone that we have for women. And so what we do is we give you testosterone and we have you use a tenth of the dose that we would normally prescribe to a man. Okay. And so we give you a tenth of that dose and then we follow levels. Okay, so it affects about 30% of postmenopausal women, and only 10% of those women are actually being treated. So it's really important for us to ask about sexual satisfaction, low desire, all of those things in postmenopause, because we know that women are often, first of all, not really being treated for low desire, but also because you want to make sure that you are addressing all the aspects of a person's life, right? So for women with breast cancer alone, testosterone alone without estrogen may improve the quality of life and is an effective option for hyperactive sexual desire disorder without estrogen receptor stimulation. Okay, so that's really, really important. Next topic we have is breast cancer and menopause. Okay, so breast cancer and hormone therapy. So breast cancer is really, really nuanced. You can't really say that just, that it is only for a certain patient population. So estrogen alone, we know that as, let's say, if somebody doesn't have a uterus, we know that we can use estrogen alone. And in the WHI study, the estrogen only arm, women that had undergone hysterectomy received conjugated equine estrogen alone without medroxyprogesterone acetate. And what we noted was that there was a reduced breast cancer risk, right? Breast cancer incidence, specifically 8 fewer cases per 10,000 women years. After 20 years of follow-up published by Chablowski and colleagues, estrogen alone was associated with 23% reduction in breast cancer and a 40% reduction in breast cancer mortality. Okay, so that's really important. Okay, so if you don't have a uterus and if you have no contraindications to hormone therapy, consider getting it because it is really life-saving. The most important results of 20 years of median follow-up of the WHI confirm that menopausal hormonal therapy does not, I reiterate, does not increase breast cancer mortality, and there was not statistically significant effect of menopausal hormonal therapy, but there was a statistically significant reduction in breast cancer mortality. Okay. And formulation, we know through that French study, right, that E3N cohort study, found that transdermal estradiol combined with micronized progesterone was not associated with an increased breast cancer risk over 8 years. Okay, so again, remember we're talking about body identical hormones, so that's why those really matter. Duration reversibility, so the risk associated with the combined hormone therapy, what we're talking about is the conjugated equine with the medroxyprogesterone acetate when present appears to emerge approximately 5 years of use and returns toward baseline after discontinuation. So we're talking about the non-body identical hormones. We're talking about the conjugated equine estrogen and the medroxyprogesterone acetate, right? If you're treating 1,000 women for 5 years with conjugated equine estrogen plus medroxyprogesterone acetate, the expected additional breast cancer diagnosis would approximate to about 4 to 5. For transdermal estradiol plus micronized progesterone, the number appears to be 0 on the best available data. So remember, if you can at all, go on the body identical hormones because they appear to have the greatest safety profile. So menopause in menopausal hormonal therapy in breast cancer survivors. Okay, so this is where the nuance really comes in, right? So the standard guideline position is clear. Menopausal hormonal therapy is generally contraindicated in women with a history of breast cancer, especially those that are hormone receptor positive breast cancer, okay? Women with ER positive, PR positive breast cancer are typically treated with endocrine therapies, either tamoxifen or aromatase inhibitors, which suppress estrogen synthesis. Adding systemic estrogen to an aromatase inhibitor is counterproductive, right? That makes sense. So if something is sensitive to, right, like so if the cancer is sensitive to the hormones, if we're adding the hormones, we're worried that, it's going to negate the mechanism of the cancer treatment, right? But we also know that from the habits trial, right, was stopped early due to an increased risk of local or contralateral breast cancer recurrence. And that was the only study that showed that. Non-hormonal options always, can be considered first line in breast cancer survivors if you're worried. Where the nuance exists is if you have, let's say, triple negative breast cancer, that has no estrogen receptor involvement in its biology, right? So for women with severe refractory menopausal symptoms after triple negative breast cancer who have completed treatment, menopausal hormonal therapy is not clearly contraindicated. And you have to talk to the oncology team, right? You have to see, is that something that, the patient can get? Okay. Tamoxifen and estrogen. Some evidence suggests that a systemic estrogen with progesterone alongside tamoxifen may be considered for severe symptoms. Again, you want to speak to the oncologist and do shared clinical decision making. Local vaginal estrogen is considered safe in most patients and in breast cancer survivors. Okay, so particularly women not on aromatase inhibitors. So again, speak with their oncologist. Testosterone alone without estrogen does not stimulate estrogen receptors directly. And so, it can improve quality of life and sexual function in breast cancer survivors. So it's an option worth discussing with the oncology team. The principle underlying all of this, right, is for patients that have had breast cancer and want to know whether or not they can get hormones. It's really nuanced. And so it really is important to go to somebody that understands this very well. So the non-hormonal alternatives that people can have that have breast cancer are, the fezolinetant, which was approved a few years ago. And then we also have another one, elinzanetant, Linquid, which was also approved last year in 2025. And we see that they both can decrease hot flashes and night sweats for those individuals that are not able to take hormones and want something for their hot flashes. For GSM, right, is aspemifene is an oral serum, which was approved for pain with sex. Progesterone is also something that you can use. Okay. And of course, both things, anytime, so we like to do shared decision making, right? But like if you are, let's say that you have breast cancer and you wanted some hormones, you have to have your gynecologist and your breast cancer specialist discuss at the same time. Discuss it with each other to make sure that you're getting the best possible. Cardiovascular disease, let's talk about that really quick. Okay, so cardiovascular disease is the leading cause of death in postmenopausal women, kills more women in every decade of life past age 40 than breast cancer does. And yet menopause as a cardiovascular risk transition point systemically under-recognized in clinical practice. So that's really important. So here we are. Cardiovascular. So estrogen is vasodilatory. We know that. We know it's anti-inflammatory, anti-atherogenic effects. Those are the effects that it has on the endothelium. And so these effects are time dependent and the endothelium dependent, meaning that they require a healthy, compliant vascular wall to manifest. So that's why the timing of hormones is super duper important. Okay, so multiple analysis, including the Cochrane Review and the WHI 18-year follow-up, show that beginning hormones less than the age of 60 or within 10 years has the most amount of benefit, and it reduces coronary heart disease incidence and all-cause mortality. The AHA 2020 scientific statement acknowledges that this benefit, while noting that menopausal hormonal therapy is not recommended as a primary cardiovascular disease prevention strategy. Okay, so you can take hormones, right? But know that it's not recommended as a first-line treatment to prevent heart disease. And so there were a few trials that took a look at this, right? And so we have the ELITE trial and the KEEPS trial, and the ELITE trial noted that women that began hormones within 6 years of menopause showed significantly lower progression to carotid intima media thickness, right, than women who initiated more than 10 years in postmenopause actually showed no benefit. So this is really important. Okay, so the KEEPS trial. The KEEPS trial found that both oral and transdermal estrogen did not increase carotid intima media thickness in early postmenopausal women for about 4 years. And so this shows us that when menopausal hormonal therapy is started in that critical window, it does not accelerate subclinical cardiovascular disease. Okay, so really important. So if you get nothing out of this, right? I know this is a very long talk, but if you get nothing out of this, know that initiating hormones in that critical window is when you get the most amount of benefit. We know that when there's a decline in estrogen during and after menopause, a lot of cardiovascular changes occur. So the LDL cholesterol rises, HDL falls, triglycerides increase, blood pressure tends to rise, the abdominal fat accumulates, arterial stiffness happens, right? So all of this stuff. The most important clinical concept to understand about hormone therapy and cardiovascular disease is a cardiovascular risk is associated with hormone therapy depends critically on when it is initiated, right? So we know that within 10 years of menopause or less than the age of 60, hormone therapy is generally safe, and the risk of cardiovascular events is low. Mortality can be reduced within that time frame, right? If it's more than 10 years after menopause, the thought here is that initiating hormones can possibly lead to an increased risk of stroke risk and is not recommended as a primary initiation. Between the ages of six, right? So greater than 60 or more than 10 years out. One of the most clinically significant aspects of hormone therapy is its interaction with lipids and how it really varies depending on the route of delivery, oral versus transdermal. Okay. What is menopausal hormonal therapy not for? So the Menopause Society and the HA outline, they say that menopausal hormonal therapy is not recommended for primary or secondary prevention of cardiovascular disease. Okay. So we don't want to be prescribing menopausal hormonal therapy to an asymptomatic woman for the purposes of preventing heart disease, because that's not the way that it works. But for a symptomatic woman, okay, under the age of 60 with bothersome vasomotor symptoms and no contraindications, then menopausal hormonal therapy is absolutely appropriate. Okay. And it's found that if it's initiated within that specific window that we keep talking about over and over again, that it roughly halves this coronary heart disease risk. And there is a 30% lower all cause mortality that has been noted. Okay. So, how do we apply all this information to, evidence-based practice? So, what we want is that for somebody, so let's say that, somebody comes in and nobody's going to be perfect, right? Some people have a high blood pressure, some people already have high cholesterol, all these things already in. So what are some things that you can use? So for somebody that's controlled high blood pressure, menopausal hormonal therapy is acceptable with blood pressure monitoring. Transdermal, of course, is the preferred route of giving hormones to somebody that already has high blood pressure, right? Because we know that sometimes estrogen can increase the blood pressure. Somebody that has high cholesterol, right? Transdermal estrogen is strongly preferred. Oral estrogen can increase the triglycerides and worsen the lipid profile. Transdermal estrogen, in contrast, may actually improve lipid parameters by increasing HDL and reducing the LDL. Prior blood clots or PE, this is generally contraindication for menopausal hormonal therapy, especially oral. And if hormones are being considered with a woman with severe refractory symptoms, then it should only be via the transdermal, right? Only through the skin. And to have a hematology consult and a thorough blood clotting workup. So for somebody that has a history of blood clots or PE, you want to try to use the transdermal route, right? Okay. Also, let's see here. So if you have your ASCVD risk, right, that is the risk score for heart disease, coronary vascular disease. Okay. So when you are applying this information to somebody that is postmenopausal, you're looking at, what is their blood pressure? You're looking at their cholesterol. You're looking to see if they have had prior blood clot or PE. You're also looking at their ASCVD risk. You want to make sure it's less than 10% in a woman under the age of 60. Okay, so this is your classic favorable scenario. Metabolic syndrome and diabetes prevention. So next, metabolic syndrome. So the Endocrine Society specifically recommends the transdermal route for somebody that has metabolic syndrome. Diabetes prevention, menopausal hormonal therapy can reduce the onset of type 2 diabetes, which is amazing. Okay, and then really quickly, we have some non-hormonal options, right? So we have fezolinetant, which is a neurokinin 3 receptor antagonist. We have elanzanitant, right, which is a dual neurokinin 1 and 3 receptor antagonist. It blocks both receptors in thermoregulation. It can also make you sleepy, right? So just so that you know, for people that are struggling with sleep, maybe, and you can't take hormones, maybe Linquit, right, or elanzanitant could be your option, right? So important to figure that out. Okay. Other non-hormonal options, we have paroxetine, we have gabapentin, we have CBT, all of those things, right? All right. So in conclusion, finally here, woohoo, summary of the consensus. So the 2002 Menopause Society position statement is the most comprehensive and authoritative summary of the current evidence that we have right now for menopausal hormonal therapy. Menopausal hormonal therapy remains the most effective treatment for bothersome VMS right? Vasomotor symptoms and GSM, and it's the highest patient satisfaction for any menopausal intervention. 75% reduction in vasomotor symptom frequency, which was confirmed by the Cochrane Review. 2, for healthy symptomatic women under the age of 60 within 10 years of menopause, the benefits of menopausal hormonal therapy outweigh the risks. 3, there's no evidence that menopausal hormonal therapy causes de novo cardiovascular disease in women who start within the critical window. 4, the absolute risk increase in breast cancer associated with menopausal hormonal therapy. Okay, where it exists, if it does, it's primarily with not body identical hormones. So it's with conjugated equine estrogen plus medroxyprogesterone. Remember that into the WHI, that was not clinically significant. But here, it's less than one additional case per 1,000 women a year, and this is smaller than the absolute risk associated with obesity and alcohol, which, a lot of people are drinking still, right? So they're drinking, and a lot of people are obese. So we know that that can also increase a person's risk of breast cancer, right? Number 5, duration of use is not arbitrarily limited. So we know that we don't have to do the shortest amount of time, right? We can, as long as the patient is being followed, treatment duration is really determined by the patient's symptoms, her risk profile, and the shared decision making. Okay, so that's really important. Number 6, so FDA-approved body identical hormones, estradiol, progesterone, are preferred over the compounded hormones. Compounded preparations, we know, lack standardization. Potency is not consistent. And so it's because we don't know what's going on with compounded hormones. It's really important just to try to use the FDA-approved ones if you can, right? Okay, finally, MHT is not appropriate for secondary or primary prevention of coronary vascular disease, or for endometrial cancer, breast cancer, or for dementia prevention. At this time, if patients ask, the answer is still no, but hormones do help, right? We know that. We saw that. We went over it. So hormones do help with, preventing diabetes, helping. They do so much, right? They help with the genitourinary syndrome of menopause. They help with bones. They help with hot flashes, all of that stuff. Okay. So in conclusion, the thing that I want to leave you with is this. 7 take-home points. The WHI did not condemn the menopausal hormonal therapy. Number 2, the FDA removal of the black box warning is a paradigm shift. Number 3, formulation and route selection determine the risk profile, right? So that's really important. Number 4, shared decision-making, validated symptom tools, and individualized cardiovascular risk stratification are the standard of care. Number 5, there's no arbitrary duration limits, which is really important. Number 6, testosterone is the most underutilized hormone in women's health. We know that. Typically used for decreased libido, right? Hyperactive sexual desire disorder. But it is a great hormone if you can get it. And lastly, so the non-hormonal toolkit has grown. We have the neurokinin receptors, elanzinitant and fezolinetant. So we know that fezolinetant and elanzinitant give us effective NK3 pathway options for women who are not able to take hormones or can't take them, right? So that's really important to know. I'll close with this. You know that your patients, the ones that wake up 4 times a night, the ones who can't have sex with their partner without pain, the ones who feel like they've lost themselves, they're waiting for you. They're waiting to listen to this conversation. So oftentimes we're told that there's something wrong with us, but there isn't. You just need the right information. So anyways, that was a lot. So if you like this episode, share it with somebody you know, somebody you don't know, right? It's important information. And well, we are done here, and it's been real and really intimate. And remember, this is not meant to be any type of medical advice. So if you're seeking help on hormones and you want to know whether or not you can get them, make sure you go speak with your friendly neighborhood healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.